Hi, my name is Dr. John. Today I will demonstrate to you how to do a knee examination. We have Mr. Daniel here, who is our simulated patient for today. Okay, Daniel, can I have you to stand up, please? Okay, thank you. Now I need to roll up your trousers, okay, so that we get better exposure. Okay, for better exposure, ideally we should either ask the patient to roll up the pants up to the thigh level, or better still, if the patient is wearing shorts, then we ask the patient to just wear the shorts. Okay, thanks Daniel for undressing to your shorts. Okay, now I will do inspection. So we will normally do inspection from the front, the side and the back. So either we can walk around the patient or we ask the patient to turn. Okay? So for inspection, we see from the front, the side and the back. So either we go around the patient or we ask the patient to turn around. Okay, as we can see from the front, Daniel's lower limbs are in good alignment. Okay, there's no muscle wasting, there's no swelling, but there's a scar over the left knee. Now Daniel, can I ask you to turn to your right, please? Thank you. So looking from the side, we look at the patient's knee joint, whether there is any contracture. Okay, at the moment, I don't see any contracture. Now Daniel, could you face the back, please? Okay, when we look at the back of the knee, we look at swelling, any swelling, for example, any meniscus cyst or Baker's cyst, or any scars which are not evident in this patient. Okay, now that we are done with inspection, we'll ask the patient to walk. I prefer this to be done before the patient lies on the couch so that we don't forget to assess the patient's gait. Now Daniel, can I have you to walk towards the sink and back? Okay, we observe the patient's swing and stun phases to look for any abnormalities. Thank you, Daniel. Ideally, we ask the patient to walk without any footwear so that we can observe any issues with the feet and ankle. Okay. Now that we have finished observing the gait, I'll ask the patient to sit on the couch and observe the movement of the knee. Daniel, can you sit on the couch, please? Now I'll ask you to slowly straighten both legs and then back again. Okay, and bend them again. So what we're observing here is the movement of the patella. So the movement of the patella, again please, normally follows an inverted J. But sometimes you can see the abnormal movement if the patella goes laterally. In this case, the movements are normal. At this point, it will be good to do a quick palpation of the knees, particularly to look for any crepitus before the patient lies down on the couch. Okay, I've already washed my hands with alcohol rub. Daniel, can I ask you to straighten your legs again, please? Slowly. One by one. The left side first. Straighten your leg, like just now. Yeah. Okay, and down again. Straighten. So I do not feel any crepitus. Okay, and this side, on the right leg. Okay, down. Up again. Down. Okay, I don't feel any crepitus. Okay, now I'll ask the patient to lie down. Daniel, can you lie down, please, on the couch? Okay, now that the patient is lying on the couch, before you forget, it's good to stand at the foot of the bed just to have a look at the alignment again, particularly looking at the medial sulcus, because obliteration of the medial sulcus will show that there is some knee effusion. Now we go to palpation. So I prefer to palpate with the knees in flexion. But before we do that, we will examine for any knee effusion. As I mentioned just now, if there's obliteration of the medial sulcus, then there is a sign of effusion. So effusions can be mild to moderate or severe or large effusions. Okay, we start with a mild to moderate effusion first. Okay, we will do what we call a bulge test. To look for a mild to moderate knee effusion, what we do is we need to empty the medial sulcus first to get the fluid back into the suprapatellar pouch. And then using the other hand, we give a gentle push to fill up that area again. So evidently there is no knee effusion because the medial sulcus is still evident. Sometimes you can do this as well to get the fluid back in. And maybe you can make it out. But it's not there because there's no knee effusion. If there is a large knee effusion, you can do a patellar tap. So patellar tap you can do either with one finger, 2 fingers, or I prefer 2 fingers and thumb because it's stable. Sometimes you can do this as well, but not really necessary, just to support the knee. Now that we've examined for knee effusion, it's time to palpate. So I prefer to palpate with the knees in 90 degrees flexion. So Daniel, can you bend your knees please, around 90 degrees? Okay, very good, both knees. Okay, and then before we touch the patient, any pain? No pain. Alright. So to do palpation, you have to do it in a systematic way. You can either do it from proximal to distal, or you can do from lateral to medial. Okay, I normally start with the bony prominences first. So, any pain here? No? Okay. This is the tibial tuberosity. This is the medial tibial plateau. Okay. Distal femur, medial aspect. Right, patella itself. Okay. Lateral part of the distal femur and lateral part of the tibial plateau. Any pain? No. Since there's no pain over the bony prominences, I'll go to the lateral joint line. This is the lateral joint line. If there's any pain, that would indicate a meniscal injury. Similarly for the medial joint line. Any pain?
No.
No, very good. If there's pain at the tibial plateau or over the distal femur, that could be signs of osteoarthritis as well. Okay, now that we are done with the inspection and palpation, we go to the movement part. So Daniel, can I ask you to lift up your legs with the knee straightened, both? Okay, now that we are done with the inspection and palpation, we go to the movement. So Daniel, can you bend your knees all the way? Very good. Now straighten your knees, please. Okay, and again. Straighten your knees. Okay, bend again. Okay, very good. Okay, if for example, Daniel is not able to fully straighten, then we need to check whether it is an extension leg or flexion deformity. If I can passively correct like this, then it's an extension leg. But if I'm unable to correct it, then it's a flexion deformity. Okay, similarly, when patient bends the knee, if it's not full range of movement, and I can bend further, then the condition is not a contracture. Okay, now we are done with the movement. I shall proceed to the special test. So for the special test, I will do the test that involves examining the ligaments first. So first we shall examine the cruciate ligaments. Daniel, can I have you to bend your knees 90 degrees? I'll do it for you. Okay. And then I will sit over here. Alright. So before we secure or anchor the feet by sitting on it, Michelle, important thing is to look for any posterior sagging. So normally this medial part of the tibial plateau is protruding. If you don't see this part, it means there is posterior sagging, and you need to correct it first before you do the drawer test. Alright, so it's important to rule out the posterior sagging by looking at the medial tibial plateau from the side, and which I don't see that there's any posterior sagging. Secondly, I'll do this to make the hamstrings relax. Okay, a patient that is not relaxed, it will be difficult to do the drawer test. And then I put both my thumbs on the tibial plateau, and I give a gentle pull. Okay, as you can see, there's no ligamentous laxity. Alright, and always compare with the other side. Okay, now for the posterior drawer, I push behind. You can see, very good. No laxity at all. Okay, if there's laxity, we look at the end point. If there is no end point or no firm end point, it means that the ligaments are completely ruptured. But if there is an end point, it means that it is a partial rupture. Okay, now that we are done with the cruciate ligaments, I will go to examine for the collateral ligaments. So for collateral ligaments, we examine with the knees in full extension and in 30 degrees of flexion. In full extension, it is a combination of cruciate ligament and collateral ligament. For example, if I do this, trying to do a valgus stress test, I'm testing for the medial collateral ligament and the anterior cruciate ligament. But when I flex the knee 30 degrees, I'm isolating the collateral ligament and just assessing for the medial collateral ligament. Okay. Similarly, when I do a varus test, the force this way, varus test, I'm examining for the lateral collateral ligament and the anterior cruciate ligament. To isolate it, I flex the knee 30 degrees. I give a varus force to isolate the lateral collateral ligament. Some of you may be wondering about the ligament test. So the ligament test is said to be a better test to test for the anterior cruciate ligament. What the test is that we flex the knee 30 degrees and then we pull the tibia anteriorly. This test may not be very easy to do and would be better done with the patient under anesthesia. Okay? Another option is to bring the knee to the side, bring it down and pull like this. For patients with patellar instability, what we can do is we can test whether the patella is subluxatable or not. And we do this not with the knees in full extension, but with the knee in 30-degree flexion. You can either use your own thigh or you can put a pillow underneath. And you try to dislocate the patella. And patella is always dislocatable laterally in patients who have patellar instability. Similarly, you do for this side, this force. To assess for patellar instability, you need to do it with the knees in about 20 to 30 degrees of flexion. And you can do this by putting your knee underneath or by putting a pillow underneath. Okay? And what you do is, you try to dislocate it laterally this way. Alright? Not so much medially. Similarly for the left knee, flex 30 degrees and bring it laterally. You can see this force.